Hello and very good evening and welcome to Biotechnica and CBI India's webinar in honor of Sjögren Day. So tomorrow marks an important occasion dedicated to raise awareness about this condition. And we are very pleased to have clinicians, pathologists, and member of patient support group joining with us today on this special occasion. Together, we aim to foster education, collaboration, and support for those who are affected. Thank you for being a part of these important initiatives. And throughout this webinar, we will hear from our expert speakers about importance of early diagnosis and treatment, and from the patient voice, how we can prevent for those who are affected. To begin with the webinar, let me invite first with Dr. Monica from Bila Lab to take us all of you through what this Sjögren syndrome is and how we can prevent for early diagnosis. Over to you, Dr. Monica.
Thank you so much, Nitin and the team Sabia, for giving me opportunity to interact with all of you and discuss about the Sjogren's disease. We just want to see a closer look. We need to understand what about this disease is, what are the various diagnostic modalities available for this, and definitely the treatment part will be covered by the clinician. So, first of all, we should understand what is Sjogren's disease. So, this was the disease which was first diagnosed by Henrik Sjogren. Initially, in 1930, he diagnosed the first case with dry mouth, dry eyes, and arthritis. These three he collectively called the Sika syndrome. And by 1933 he he found around 19 cases, but his thesis was considered as low, and he was not upgraded as a professor. But later on, with the help of other ophthalmologists, he was from Stockholm, he was also an ophthalmologist, but later on his work on Sjogren was recognized, and this disease was considered as an autoimmune disorder. So basically, Sjogren's disease is multi-system autoimmune disorders, which is primarily affecting the exocrine glands, and it is normally present with the dryness of eyes, that is called the zero ophthalmia, along with xerostomia, that is the dryness of mouth, primarily affecting salivary glands, lacrimal glands, and later on it may affect the systemic organs. This is considered as the third most common autoimmune disorder after rheumatoid arthritis and lupus. If we talk about the prevalence, there are 61 cases per 1 lakh of the population, and female predominance as with other autoimmune disorders, in which estrogen plays a very important role. Uh, Primarily, I will talk about the age. Any age can be affected, but usually between the age of 40 to 50 years, most common age group which is affected with the Sjogren's disease. About the etiology, now there are various etiological factors are there, in which the most common is the genetic predisposition with the HLA, DR, and DQ allele, HLA involvement is there. And there is very interesting thing that there are certain viruses, that is the environmental factors are also there, in which the stated viruses, Epstein-Barr virus, HTLV, HHV6, HIV, HCV, and cytomegalovirus. These are the viruses which also contribute in the development of this disease. There is one very interesting paper I was going through, in which say it was mentioning that exposure to long term of carbon monoxide and nitric oxide with methane can be a factor which may lead to a development of Sjogren's disease in a patient. And normally, the females with the primary relatives who are with autoimmune disorders, that is comes in the genetic predisposition of the development of Sjogren's disease. Now we talk about the clinical features. Yes, because the lacrimal and salivary glands are affected primarily, so there are patients are mainly present with the dry eyes and dry mouth. There is a gritty sensation in the eyes, and there is a difficulty in swallowing. And main gland which is primarily affected even in children also, this is the first sign we can identify it in the children with the Sjogren's disease, is the parotid swelling. If I'll talk about the systemic involvement, yes, main organs which are affected are the after that eyes and mouth are the lungs, kidney, and nerves. Joints, then definitely they are also affected. The long-term complication I'll talk about it is the non-Hodgkin's lymphoma. In the 5 to 10% of the primary Sjogren's disease patients may develop the non-Hodgkin's lymphoma in their life course. Along with, because there is a dryness, so they are more prone to develop infections, and there is a particular antibody which we say RO52. They may develop ILD in lung. So if I'll talk about the types, there are two types of Sjogren's disease, that is primary as well as secondary. Primary means there is no other systemic involvement is there, only the glands, salivary glands and the lacrimal glands are affected. In the secondary Sjogren's, they are usually associated with the other connective tissue or the systemic disorders like SLE or rheumatoid arthritis and primary biliary cirrhosis or hepatitis cases, autoimmune hepatitis, and the polymyositis cases. This secondary Sjogren's disease is also considered as Sjogren disease with overlap. So secondary and with overlap is almost same. There was a criteria, there is specific classification criteria for the diagnosis of Sjogren disease. It was proposed by in 2002 by the American European Association, in which they have used the broader based and ocular and oral symptoms. They take as a more weightage they have given to the ocular symptoms, oral symptoms, and ocular signs, along with the histopathology and the salivary signs. With they included the or two most important antibodies in that auto antibodies, that is basically the SSA RO, and second one is the SSB LA. These two antibodies were considered in their classification criteria. They have included certain exclusion criteria also in that. This was upgraded in 2012 by the Sika Association. They have included certain things, but final consensus criteria was released in 2016, in which for the primary Sjogren disease or syndrome diagnosis, they have included five criteria, in which they have included the biopsy as well as the antibodies only to anti-SSA RO. Please see that SSB was excluded. They excluded this in 2016 consensus criteria. Then there is ocular staining score, Schirmer test, and there is a saliva flow rate. So if total or more four or more than of these criteria met, then the patient is considered as a case of primary Sjogren's disease or syndrome. Uh, Also, there are exclusion criteria which was stated in 2002 also, but they have included certain inclusion criteria. I think this will be further explained by our eminent clinician in the panel group. Uh, Now come to the laboratory diagnosis, as auto antibodies are involved in the consensus criteria. So there in 2002 there were two antibodies, and in 2016 SSA-RO antibodies is there. So how we are going to see these antibodies? There are three modalities by which we will be able to detect these antibodies. Most important is the indirect immunofluorescence. In this, the AC4, that is an ICAP pattern, which is AC4 pattern, which is, it is a granular, speckled granular pattern, specific for SSA as well as for SSB, and there are certain other autoantibodies also. If I talk about SSB, yes, it is more specific for Sjogren's, but it was not included. As I already said, it was not included in consensus criteria 2016. We can detect, the quantitation can be done of these antibodies by ELISA also, and we can see these antibodies in immunoblot assay also. So they have not explained that, because SSA-RO antibodies are of two, that is the 16 kd and 52 kd. So they have not specified 60 kd should be included, or RO52 or TRIM21 should be included. So in Sjogren's, both the antibodies can be included when we are going as per the consensus criteria. There are very rare cases in which SSB without SSA-RO is seen. If it is there, that you need to check for the presence of primary biliary cirrhosis or autoimmune hepatitis association. There are other also laboratory testing available. We should go for in the diagnosis of Sjogren's disease is mainly the ESR. If there is a presence CBC, if you see the anemia or leukopenia or eosinophilia, and that most of the kidney affected patients, they may present with the hypergamma anti alpha 14 antibodies. Nowadays it is said that it is can be a reliable marker in juvenile Sjogren's syndrome. Creatinine clearance if the kidney is affected. Yes, this is a very interesting thing. Usually, we see that the rheumatoid factor is associated with rheumatoid arthritis cases, but in Sjogren's, in 52% cases, in primary Sjogren, rheumatoid factor is present, and if it is there, it independently associated with the development of non-Hodgkin's lymphoma in these patients. And there is very interesting thing that females are more prone to develop the Sjogren syndrome. But if male is there, then definitely the severity of the disease is more in male in comparison to females. And this rheumatoid factor is around 98% positivity in the secondary cases, even without presence of rheumatoid arthritis. And yes, if the Sjogren syndrome is associated with primary biliary cirrhosis, then you have to check for the alkaline phosphatase and SGOT, SGPT levels also. So, in to short, if I'll say yes, Sjogren can sometimes be the diagnosis. It is basically the art, which is based on the assessment of physician, taking the symptoms and sign into consideration along with the tests available for the diagnosis of this disease. Thank you so much.
uh, Dr. Monica. Thank you, Dr. Monica, once again for sharing your wonderful perspective about the disease and importance of diagnosis and what are the laboratory testing which is available and kind of evolving as we go along the great journey of better diagnosing the patient. Now, I would like to invite Dr. Siddharth Sharma, who is the clinical affair manager with CBI India. Dr. Siddharth will share his view from a CBI perspective, how CBI is kind of playing an important role supporting the lab and in between, working with clinicians also indirectly to, support and better diagnose of this disease. And then he will also take over for the great discussion which we will have today with all the eminent speakers, patient support users, and clinicians. Over to you, Dr. Siddharth.
Okay, great. So thank you, Nitin, and thank you, Dr. Monica, for such a wonderful presentation in which you have beautifully elucidated the history and the current diagnostic modalities and also the clinical features which are present in Sjogren's syndrome and how it's a diagnostic mystery and boils down to the clinician's art in picking up this disease. So, going on further, what I would be talking about is basically how Sabia, as a company with its ELISA monotest technology, can play a very important role in the diagnosis of Sjogren's syndrome. So, just a brief context of on the autoimmunity when we talk about the SARDs or the systemic autoimmune rheumatic disorders. This is the whole spectrum of the autoimmune rheumatic disorders which have a systemic manifestation. So it boils down to that many of them, around 99% of the SRDs, are basically connective tissue diseases. And in that, we have various categories based on the primary organ system which is affected and also the multi-systemic involvement that disease shows. So we have the SLE, we have Sharp syndrome, we have Sjogren's, which is part of the this disease spectrum, then systemic sclerosis, polymyositis, dermatomyositis, and to a certain extent, ANCA-associated vasculitis. So Sjogren syndrome is a part of a systemic autoimmune rheumatic disorder, which is invariably a connective tissue disorder or a disease. Whenever we do a diagnostic flow for picking up any autoimmune disorder, this is the process flow which is usually followed by the clinicians and the laboratories. We have the initial screening step, which is done on the by IFA methodology by using Hep2 cells or tissues. And this test has a higher sensitivity. So it is basically meant to pick up a disease. But then going further, if we have picked up a disease, we need to confirm the disease. And for confirmation, we need to rely on the solid phase assays or the SPAs, which offer a higher specificity. And then further differentiation of a particular autoimmune rheumatic disorder or a connective tissue disorder is required. And in that, again, we have to rely on the solid phase assay, in which a single antigen or a profile mixture of a profile antigen testing is done. And definitely, this also has a higher specificity and helps in the confirmation and differentiation of a particular autoimmune disorder. So, broadly, this is the process flow which is followed for picking up any autoimmune rheumatic disorder. Sabia has sort of stepped in and has provided a excellent innovation of more than 15 years when it comes to the process flow which is present in picking up these autoimmune disorders by having a lab on a strip solution. Sabia has a ready to use reagents which is pre-filled in a Allegria monotest strips. Allegria is a brand name of the instrument, which is an ELISA based instrument, which I will be talking about in my subsequent slides. And these strips are barcoded, where the barcode has all the relevant informations on the calibration curve, the product information, and also the expiry date. What is unique to these strips is the SMC technology, which is the sensotronic memorized calibration, which is basically a virtual calibration curve which is formed by the instrument on reading the strip barcode, where a 4 point calibration curve is generated and compared to a manual ELISA calibration curve which needs to be generated manually, which is prone to lot of errors. This error concept is negated by the incorporation of this SMC technology. Also, it enhances the workflow in the laboratory. Also, each test is validated and generates high quality test results. So this is what the SMC technology is. It's a sensotronic memorized calibration where each monotest strip is sealed with a special foil. If you can see the illustration on the screen, you can see a strip, a series of wells, which is what we call a monotest strip, and this is covered with a special seal which has a barcode on it, and this is the barcode containing the calibration information, which is then read by the instrument, and a 4 point virtual calibration curve is generated, and then the further testing of the patient sample is done based on this 4 point generation of the virtual curve. And this curve is unique for each strip, although it is lot specific. Each test, when it is run simultaneously, a 4 point virtual calibration curve is also generated. The basic principle of this test is ELISA. It's a very simple test. There are 8 wells in the strip, out of which the initial four wells are empty wells, where the reaction of both the sample as well control is done. It is in the well, if you see the well 5 is where, if I can move my pointer, if you see well 5 is where the inbuilt control strip control is there. This control acts as a integrity control which checks the integrity of the strip. If there is a deterioration of the reagents or of the strip due to any reason, improper storage, it will not allow the test to proceed further. And this is very reliable in case there is improper storage, reagent deterioration, and wrong results may be generated if we are doing a manual ELISA. Because of this inbuilt check control in the strip, that problem is overcome, and instead of generating an inaccurate result, you have no result which is generated, which helps in proper patient reports. So if there is a any strip problem, the control will deteriorate. It will not allow the test to progress further and will not lead to release of wrong reports for the patients. And these are the other 3 wells in which the inbuilt conjugate, the sample dilution buffer, and the substrate are all pre-filled. So basically, all the reagents are pre-filled in the strip. That is how it helps in saving the reagents, prevents reagent wastage compared to a conventional ELISA technique which is done in the laboratory. Uh, these strips are run in an instrument. So this figure shows there are 2 instruments which are available in the Sabia product portfolio. We have the Allegria 2 and the Allegria 1. Both of them have monotest strips in which the patient sample is placed and then the sample is processed by the instrument. The difference between Allegria 2 and Allegria 1 is the automation. Allegria 2 is a fully automated instrument, whereas Allegria 1 is a semi automated instrument. The throughput of Allegria 2 is 240 tests in less than 8 hours, whereas in Allegria 1 it is 90 tests in 8 hours. The test capacity for Allegria 2 is you can do up to 80 different assays in one go, whereas in Allegria 1 you can do up to 30 assays in one go. And another unique aspect is here the batching of samples is not required. Allegria 2 is a random access instrument, whereas in Allegria 1, the batching is not required. So basically, serum, plasma, stool, all samples can be run together. There is no need to separately segregate or run serum samples, plasma samples, or stool samples. Irrespective of the sample size, irrespective of the sample type, they can all be run simultaneously. Allegria 2 is more suited for a laboratory which has a high volume of testing, around 100 to 300 tests per day, whereas Allegria 1 is more suited for a low to medium volume lab which is catering to around 50 to 100 autoimmune tests per day. Both of these systems rely on the ELISA monotest technology. When we compare the Sabia Allegria system with the manual ELISA, these are some points which help any laboratory which is having a conventional or a traditional ELISA system for autoimmunity testing by converting into a semi or a fully automated testing. Also, the calibration is an important part. The sensotronic memorized calibration helps in generation of a virtual calibration curve, negates the process of generating a manual curve preparation, which at many a times is prone to error, and you do not get a proper calibration curve, which it depends on how the overall processing has been done. So this process is negated by using an Allegria system. It helps the laboratory in sort of simplifying the workflow, and also in helps in further reducing the TAT of report generation. The turnaround time, definitely, as I told you before, is fast in Allegria system, and the reagent preparation, a lot of manual handling is required by doing a conventional ELISA testing, whereas in Allegria system, all the reagents are pre-filled in the strips, so there is no need of adding any extra reagent. Also, the chances of reagent wastage are less in Allegria system compared to a manual conventional ELISA testing. Also, the risk of human error, which is very important when it comes to ELISA testing, is minimal in Allegria monotest technology, where in Allegria 1 you just need to pipette 10 microliter of sample, whereas in Allegria 2 automated pipetting is done from by the instrument from the primary sample tube, whereas in traditional ELISA, definitely the chances of human error are high, and based on the type of pipetting or how the pipetting of the samples and the various reagents is done. So Sabia has devised, it has in its product portfolio the products which, although have not hit the Indian market, but I have displayed them here. We have a fully automated tissue processor for IFA screening. We have a AI generated image analyzer, which is goes by the name of Define Automated Microscope, which uses Hep2 cells to have a classification of the various cell patterns based on the ICAP classification. It is AI enabled. But what we have right now in India is the Allegria 2, which I told you is a automated ELISA instrument. The Sabia is a part and parcel of whether it is the screening aspect or the diagnostic or the confirmatory aspect of any autoimmune laboratory, right? By having the automated sample processor, the defined automated microscope, which analyzes the IFA images based on an AI algorithm, and Allegria 2, which is an ELISA based instrument. Coming to Sjogren syndrome specifically, what I have highlighted here, and I picked them up from a book called Sjogren's syndrome. So the name of the book is interesting. It's called Sjogren syndrome. It's a book totally devoted to Sjogren's syndrome. These are the various antigens which are present in Sjogren's syndrome, and Dr. Monica has already elucidated on the antigens which form the part of the classification criteria of Sjogren's syndrome. So, if we see the prevalence, row 52 and row 60, which are subsets of anti row or SSA, as we say, constitutes around 66.7 and 52.1% respectively. Rheumatoid factor, interestingly, also constitutes is seen in good number of patients in Sjogren syndrome. Also, alpha fodrin is seen in major in a good number of patients of Sjogren syndrome. So basically, we have row 52, row 60, SSB or anti-La and alpha fodrin, which are some of the major antigens against which antibodies are formed in Sjogren syndrome. And these antibodies or these antigens have antibodies against these antigens have various clinical manifestations which they are indicative of. And row 52, row 60, the clinical associations are listed here. And when we talk of alpha fodrin, which is now recently discovered antibody antigen against which the antibodies have been discovered, they have a marker. They are markers of lymphocytic infiltration of salivary glands, also of Sika syndrome, and also of CNS involvement in a Sjogren's syndrome. So when we talk of Allegria monotest, there is a good portfolio for connective tissue disorders in which we have all the disorders listed, in which the antigen antibodies against Sjogren's syndrome also form a part and parcel of the product portfolio. Any lab doing a testing for Sjogren's syndrome will find the presence of anti-SSA, also subtypes of SSA 52, SSA 60, SSB, as well as anti-alpha fodrin IgG as a part of the Sabia portfolio, and can help if you are using the Allegria system in a generation of fast reports in a suspected Sjogren's patient. So this is a patient's journey in which Sabia forms a part and parcel in the diagnostic pathway of Sjogren's syndrome in a patient, right from HEP2 screening to differentiation of the disease based on the ELISA technology the portfolio has. With that, I will end my session, and I guess, Nitin, I can start with the panel discussion now, right?
Yes.
Great.
So we
Nitin,
can, yeah, we can start with the theme.
yeah. So, Nitin, would you be introducing the panelists?
No, I think you can just go ahead with the flow. We have
Sure.
everybody.
Fine. Okay. So, good evening, everyone, and welcome to this panel discussion on a disease which is very common but overlooked. It's a autoimmune disorder that goes far beyond the dry eyes and dry mouth as we commonly know. In India, the challenges are compounded because of limited awareness, delayed diagnosis, and also lack of structured treatment plans, especially in rural areas of the country. Despite affecting quality of life and activities of daily living, Sjogren's is not yet recognized, unfortunately, under the India's Disability Act. Socio-cultural taboos, changing age patterns, and poor representation in medical curricula further deepen this gap. So today's panel brings together experts across disciplines to explore and discuss on the approach to improve diagnosis, education, access, and also long-term care for patients with Sjogren's syndrome in India. And to set the ball rolling, I will now put up my first set of questions to Dr. Swati Singh. Dr. Swati, welcome to the panel discussion.
Thank you so much, Dr. Siddharth.
Welcome.
Um, yeah.
Yes. So my first question to you, Dr. Swati, would be what, as an ophthalmologist, what clinical features in the dry eye disease raise suspicion for an underlying systemic condition like Sjogren's syndrome?
Okay. So, I'm sorry to correct, but now the terminology has changed and it's no longer labeled as a syndrome. So we should use only Sjogren's disease
Right.
in a recent consensus. So in our patients, most often many of the patients which I see in my OPD are commonly as a misdiagnosed as having a dry eye disease, and it is very very crucial that you know how to examine the lacrimal gland involvement in these patients. Okay, so Sjogren disease affects the exocrine glands, and in the eye, lacrimal gland is the gland which produces the aqueous component of tears, which is affected. So essentially, one should look at the function of the lacrimal gland. How can you do in our OPD? It's a 5 minute test. It's a very it's a Whatman filter paper which you can put inside your eye and keep it there for 5 minutes, and then you measure the amount of wetting. If it is less than 10 millimeters, it indicates that the function is compromised. Now, the issue here is, which I want to bring to the audience as well, is that whenever you do this test, make sure that you take care of the variabilities. So, if suppose a patient has instilled a drop, they have dry eye, they're sitting in the waiting area, they've instilled a drop, they come to you, you put the Sharma strip, the value will be very high because it will soak everything which is the drop which is present inside the eye part as well. So many of the times these patients might be labeled as not having any lacrimal gland dysfunction. And second is, many times we use a drop known as topical anesthetic, which is paracaine in the clinics, which can reduce the levels of the lacrimal gland activity. So if that has been used, again the lead reading will be very low. So whenever anybody walks into your clinic, if you're doing Shermer test, make sure that you ask the patient no drops have been instilled before the test, and have an accurate measurement by placing it in the right position in the eye. And if it is less than 10 millimeter, it indicates there is some compromise of the lacrimal gland. Next, we move on to the assessment of the cornea, which is the black part inside the eye. So we put some fluorescent stain inside. It will show the pinpoint issues, the defects in the epithelium, which happens if your lacrimal gland is compromised. So if a patient with dry eye complaints come to me and he or she has a reduced lacrimal gland activity in terms of reduced Schirmer or has a staining, then I would proceed with asking about the history of dry mouth, joint pains, and then order the investigations where we do ANA profile to know if they are seropositive or seronegative, and then accordingly we'll treat the further management.
Right. And thank you, Dr. Swati, for bringing about this important aspect of it not being a syndrome now, but being a disease, because that was one of the questions I was about to put to one of the panelists. But great, you have brought it out right at the outset. So good. That's really good. Thank you so much. So, my second question to you is, how do you interpret a severely dry ocular surface in patients without classical systemic symptoms? Rather, when should you suspect ocular only Sjogren's?
So, in at LVPI, we have developed a very easy test where you can evaluate the minor salivary gland activity. So, in my OPD, if I see that ocular dryness is present, there's no doubt about it. The next step is you ask about the dry mouth, and many times patients, they don't have that much trouble with the dryness in the mouth. They don't notice it as much as they have the disability in the eye. So they might not have dry mouth, but I will do the evaluation of the lower lip minus salivary gland activity. We published a study on that, and if that levels are reduced, then I will suspect that the patient has Sjogren's disease. And if that is absolutely normal, if there's no dry mouth, I'll do the minus salivary gland biopsy. If it is negative, in that case, then I'll label it as only ocular only Sjogren's disease. And of
Great.
course, since being a multidisciplinary, a disease which involves so many systems, so
True.
we do recommend our patients to visit our rheumatologist colleagues who will do a systemic evaluation. Sometimes these patients do not are not aware of any, the lung involvement and the kidney involvements they have. Even the skin dermatology, they'll have dry eye, sometimes rashes, but they are not so bothered about it. So once they undergo the complete evaluation, then we label whether he or she has pure ocular involvement, or there is ocular plus oral or plus systemic.
Great. Thank you for those wonderful insights. And rightly said, multisystemic disorder. And we do have a rheumatologist on our panel. So I'll be coming to him very soon. So now I'll jump over to Dr. Sayan Basu. Dr. Basu, my first question to you would be: do you find current Sjogren's syndrome diagnostic criteria inclusive enough of severe ocular presentations even when other features are absent? And I stand correct, I would say Sjogren's disease. So over to you, Dr. Basu.
Thank you so much, Dr. Sharma, and thank you, Sabia, for having me on this panel and putting together this webinar. It's an interesting question. I think that the diagnostic criteria, it has been looked at in so much detail and revised a couple of times. I don't think that the diagnosis of Sjogren syndrome is that difficult. It is just that it is, the index of suspicion should be high. So what happens is, because like you were discussing with Swati as well, that because it's a multi-system disease, what happens is that the patients are intuitively not able to make this connection that their dry eye and their dry mouth and their arthralgia are connected. And so they are seeking help from different specialists for different symptoms, and that is where our role comes in. I think the ophthalmologist plays a very important role, because I think the ophthalmologist is in a key position to diagnose Sjogren syndrome in its entirety, because at least two of the criteria are ophthalmology related. You know that the
Yeah.
patient has dry eye, and you know that the you have the wherewithal to assess the dry eye and make sure that it is aqueous deficient and the Schirmer's is low. It's difficult for other specialists to do that. So they need to send the patient to an ophthalmologist to make sure that they have the right kind of dry eye. So I think more awareness and a greater index of suspicion for patients who are coming in with dry eye symptoms, especially to the ophthalmologist, that do these patients have Sjogren, do these patients have other systemic complaints that fit into the diagnostic modality. I think that would really help in picking up these patients who are otherwise just treated for dry eyes with lubricants without being referred to a rheumatologist, because we all understand that, because the underlying systemic pathology is the same. It's the exocrine glands that are affected everywhere in the body. Systemic treatment is very important, because it not only improves the quality of vision but also the quality of the life of the patient. It's not just that the patient has dry eyes. So I think that is important. But what would really help, I think, in terms of diagnosis and the I think would help is in these patients being picked up early and being treatment being initiated early, is if we had a point of care testing for
Right.
Sjogren's. Something, I don't know how it could be, but an ELISA which is bedside, or a lateral flow assay, like a pregnancy card test where you could just take tears or blood and then get a diagnosis that the patient has Sjogren's. That would really simplify things, in addition to putting the clinical symptoms together and suspecting that the patient might have this.
No, great. And the point on a POCT test is quite relevant, and I believe we might have one in the future also. So, no, very good insights. So, my second question to you is, and already you have spoken a bit about it. So, what is your experience with coordinated care involving rheumatologists? And do you feel there is adequate feedback on diagnosis confirmation?
No, I think it's absolutely critical, because we work very closely with rheumatologists in our city, and all of our patients who come in with dry eye, they are evaluated for possible Sjogren's, and then they are referred to the rheumatologist once we suspect that. So if we have a patient who comes in with dry eyes, dry mouth, and also complains of arthralgia, then we insist and we make sure that the patient sees the rheumatologist, gets the blood workup done, and then is the systemic therapy is also initiated before we do anything definitive for the eye. And we also try to give a lot of chair time to the patient to explain this, that it is not just that the eyes are involved, and that this is a problem that is affecting, it's the same problem that is affecting different parts of the body and manifesting in different ways. And explaining that to the patient, I think, is very critical, because then only the patient realizes, because there's a lot of, you also have to understand that sending to the rheumatologist is easy. For the patient to have compliance and take that medication, they must really be convinced that this is going to help, because the effects or the benefits of the systemic therapy don't start immediately, and there is just so much of propaganda against this, against allopathic medication and their toxicity and side effects that gets talked about. And so it's important to give patient chair time and explain this. I think that if you have a rheumatologist, I think just sending a patient to the rheumatologist and saying this patient may or may not have Sjogren's, take care of it, is not enough. I think it's important to work closely and do your part. And then if you have a good partnership, then it works very well. It is, it's very difficult for the rheumatologist to just start treatment on their own without understanding, especially, like you were talking about with Swati, if you have monocyte disease, that you only have dry eyes, and you suspect that the patient has Sjogren's, patient doesn't have arthralgia, doesn't have dry mouth, doesn't have dry skin, it's very difficult for the rheumatologist to start systemic therapy unless they have that confidence that, since you're suspecting it, it could be, and then they send the blood workup, and if it comes positive, they start treatment for that. So partnership and understanding is very, very important in this relationship. And of course, you cannot treat a patient with Sjogren's syndrome well if you are not collaborating as an ophthalmologist, if you're not collaborating with the rheumatologist.
No, wonderful. And thank you for those great insights again. And now that the ophthalmologists have spoken, we come to the pivotal point, the main clinician who is uh, quite involved in the treatment and the management of this patient, Dr. Yeram, who's a rheumatologist. Welcome, Dr. Yeram, to the panel discussion.
Yeah, thank
So,
you. Thank you very much.
So, my first question to you would be, what are the most under recognized systemic manifestations of Sjogren's syndrome, neurological, renal, or pulmonary, and how should they be screened?
Uh, so, to add on to that, all systemic manifestations are under-recognized. So, most of us would be concentrating only on this ocular Sitka and oral Sitka, and sometimes we might be knowing that there can be parotid swelling. But what we should know is many organ manifestations can occur in Sjogren's disease, previously syndrome, now disease. That nomenclature we might be
Yes,
confused. So first, systemically, we can deal with that. So pulmonary involvement can be seen in Sjogren's syndrome. They can present as interstitial pneumonias, like lymphocytic interstitial pneumonia or NSIP pattern. So clinically, what would be the symptoms? There can be cough, there can be shortness of breath, and because of shortness of breath, there can be decrease in saturation of the patient. So this is symptom-wise. These symptoms can be present, and interstitial pneumonia is the cause for symptoms. When we move on to neurological manifestations, most of them can present with sensory involvement. That there can be paresthesias, there can be tingling, there can be numbness. All these symptoms can be there. And moving on, sometimes there can be weakness also, like distal involvement can be there with peripheral neuropathies, and sometimes there can be ganglionopathies, and rarely central nervous system involvement can be there. For example, like brain fog can be there, and rarely CNS vasculitis can be there. So, what would be the symptom manifestation? Like numbness, paresthesias, and brain fog. These are like symptoms can be present with CNS and PNS involvement in Sjogren's syndrome. So, when we move on to the important renal manifestations, there can be renal tubular acidosis. Thus, that is distal renal tubular acidosis. Because of these, bicarbonate will be lost, and there can be osteomalacia of bones that results in fractures. So patients can be having fractures because of this acidosis. Apart from that, there can be interstitial nephritis, and there can also rarely be glomerulonephritis. That is rarer. So important things are renal tubular acidosis and interstitial nephritis. So then we should move on to hematological manifestations. There can be leukopenias, and there can be thrombocytopenia, and there can be anemia of chronic disease. So skin manifestations are very important because they work as like peripheral markers. There can be like palpable purpura, and there can be vasculitic type of rash, and there can be acute cutaneous lupus type of rash that also can be seen in Sjogren's disease. These are predominant extraglandular manifestations of Sjogren's disease. Some risk factors can be there for extraglandular manifestations. Of those risk factors, important ones were RF positivity. So RF positivity can be present in around 50 to 70% of the patients with Sjogren's disease. If the patients have RF positivity, they are more prone for risk of extraglandular manifestations. Apart from that, patients having this vasculitic type of rash and patient having antibody positivity and low complement levels, they are also prone for development of lymphomas. These lymphomas, there can be maltomas or there can be marginal zone lymphomas or many other varieties of lymphomas can occur. Like this, different extraglandular manifestations can be present in Sjogren's disease, and high index of suspicion with proper history and appropriate investigations is needed for proper management of the patients with this Sjogren's disease.
Yes, right. And as Dr. Monica said in her presentation, clinician expertise is of paramount importance in picking up this multisystemic mysterious disease. So, my next question to you would be, in your experience, how reliable is the 2016 ACR ULAR classification in a real world clinical setting? Are we missing early or atypical cases? And also, should ANA positivity in asymptomatic individuals prompt screening for Sjogren's disease and high risk groups?
Yeah, this ACR 2016 criteria, it is the latest classification criteria that is available to us to classify Sjogren's disease. We should remember that it is for classification, not for diagnosis. So
Correct.
classification is useful for recruitment into trials, not for diagnosis. Diagnosis is purely based on clinician expertise. So the important classification criteria, the highest weightage is given to lip biopsy and later antibody positivity, that is SSC, Rho 60 antibody positivity, followed by 1 point given to ocular manifestations and regarding this dry mouth. So this ACR 2016 classification, it has few pitfalls. So the important pitfall is like early disease, which you have mentioned. So early disease, it is difficult to diagnose with ACR 2016 criteria because they might be serologically positive, but they might not be having the things that are needed for classification. And apart from that, we should always know that before applying the classification criteria, there is some inclusion criteria. That inclusion criteria is ocular and oral dryness greater than 3 months, and apart from that, we should exclude all other possibilities of dry eye and dry mouth. So important ones would be like viral infections and radiation exposure, and it can be sarcoid, it can be IgG4 disease, it can be amyloidosis. All these should be excluded. Then only we should apply the classification criteria for Sjogren disease. So, as I've already mentioned, two earlier disease cannot be classified by applying these criteria. So that's why two earlier disease, we should solely rely on history and serology, and we should not totally rely on classification criteria. And one more important thing that should be added, only for ocular and oral Zika, there is no role of immunosuppression. Will be just treating symptomatically. Only if there is organ manifestation, then we'll go with immunosuppression.
Right. No, great, great. Thank you, Dr. Yerim, for those great insights. And now that the clinicians have given us a great perspective on this disease, we move on to the laboratory aspect of this disease. And to give her insights, we have Dr. Arpita Roy. Welcome, Dr. Arpita, to this panel discussion. So, my
Hi, Dr.
first
Siddharth.
Yeah, great. Thank you, Dr. Arpita. So, my first question to you is, as a laboratorian, how reliable, I'm sorry, how reliable is EQ-IFA in detecting cytoplasmic SSA Rho 52 antibodies, and what are the implications for seronegative Sjogren's diagnosis?
Yeah, okay. Thank you for the question, Dr. Siddharth. So, as we have already heard from the clinicians and from Dr. Monica around the 2016 ACR ULAR guidelines for the thing. So there are two antibodies there that comes into play. So the anti-SSA is basically row 52 and row 60. Earlier, row 52 and 60 were originally thought to be the single protein or the same protein. But then functionally, it came out to be distinct proteins encoded by different gene on separate chromosomes. Now, if we come to the question of the reliability of Hep2 IFA, so Hep2 IFA is widely used for detecting ANA, as we all are aware, and many autoimmunity patterns associated with autoimmune diseases, including the Sjogren's disease. However, Hep2-IFA does have its limitation in the sensitivity for detecting the isolated anti-SSA, especially the Rho52 distinctive antibody. Many samples which are positive only for anti-Rho 52 do not produce a distinctive cytoplasmic pattern on the Hep2 cells, and thus may test negative on the standard Hep2 IFA if it is individually done, even when the Rho 52 antibodies are present in that sample or in that patient. So this would lead to, of course, a seronegative kind of a lookout. And if we talk about the implications here, patients with primary Sjogren's disease who are positive only for RO52 antibodies may be missed, like we just discussed on the Hep2 IFS basic screening. Uh, and this would underline the importance of additional specific immunoassays like the ELISAs or the solid immunoassays for detecting these anti-Rho52 antibodies when clinical suspicion persists, even in case of a Hep2 IFA negative case. Another thing is that, of course, the failure to detect these anti-Rho 52 can lead to delayed or misdiagnosis in a
Right.
subset of these patients, and thus, this integrated targeted anti 52 testing improves the diagnostic accuracy for seronegative cases.
Right, right. So, lot of variability associated
Yeah.
with Hep2 testing, not only with SSA antibodies, but with other antibodies related to connective tissue disorders. So, thank you so much for that great insight. And my second question is taking on from what you have already stated. So, given the non-specificity of the speckled pattern, how should clinicians interpret a positive ANA in patients with non-specific Zika symptoms? Should we, as pathologists or laboratorians, reconsider the testing sequence using ELISA or any other solid phase assay for SSA row testing before ordering a ANA test? Your thoughts on this?
Yeah, so if we ponder upon the question, a positive ANA result should be interpreted in conjunction with the patient's clinical symptoms and the medical history. So here again, when we talk about Sjogren's disease, the clinician's art is what always comes boils down to the diagnosis. But based on this evaluation, the clinician may proceed with a confirmatory test such as a line immunoassay, which is a multiplex panel offering a comprehensive overview of the various relevant antigens. As we all know, the harmonization and standardization around autoimmunity is still a vast zone. There's a lot of research and lot of things that needs to be standardized in this zone. Alternatively, if a diagnosis is strongly supported by the clinical findings, a specific ELISA test may be ordered by the clinician. While ANA-IFA remains the gold standard for ANA screening due to its ability to detect a broad range of autoantibodies, I think most specific tests are limited to fewer antigen antibody targets and carry a higher risk of false negative results. So, of course, it's a bucket of what we are testing with the clinical perspective coming into play. And I mean, the ANA might be just the starting point, and then, of course, like you showed in your slide, there is something in an ANA where it's like sensitivity is what is being picked up, and then we go into more line immunoassays or ELISAs to go on to the confirmatory methods.
No, great, great. Thank you for those wonderful insights. I'll just quickly ask Dr. Monica also, because she has been working extensively in the autoimmunity laboratory, for her thoughts on ANA testing in the laboratory. Dr. Monica, just a quick input from your side, please.
Dr. Siddharth, thank you so much. Actually, I am doing ANA for last 18 years. And if I'll say about SSA, RO, and SSB patterns, definitely we cannot say these are completely specific for any of the autoimmune disorder. There are various autoantibodies which are associated with this. And specifically, if I'll talk about RO52, that is the basically the TRIM21 antibody that is mainly associated with it, because it has a highly antigenic potential and a high affinity for lungs. So normally what I have consulted with the clinicians, most of the RO52 cases are present with the ILD. ILD associations are also there. So
Okay.
if I'll say Sjogren is completely with SSA 60 or RO52, then definitely it's a big question, because there are many other diseases which are associated with the with RO52, like dermatomyositis. You can find it in there also. If a pregnant female with SLE, then chances of congenital heart block is also there. 1% cases may present with that. So Sjogren's completely, I'll say SSA or SSB. Yes, the answer is no. So again, what I have concluded, clinician expertise is required in the final diagnosis of a patient with the dry eyes and dry mouth and any other systemic disorder, and how to interpret that ANA positivity with those clinical symptoms using all consensus criteria, and their experience will help in the final diagnosis of Sjogren's disease.
Right. Right. Thank you. Thank you so much, Dr. Monica, for those great inputs. Now that the clinicians and laboratorians have spoken, we now move to the person who faces the brunt of this disease, and that is the patient. And representing the patient, we have Ms. Kirtida Oza, who is a part of the patient advocacy group. Welcome, Ms. Kirtida, to this panel discussion.
Thank you.
And my first question to you would be, and again, it comes from what Dr. Swati stated in the beginning, but still, it will be good to have it from your side also. Do you believe it's time to shift from the term Sjogren's syndrome to Sjogren's disease? I believe it has already been done, but still would be great to have your inputs on how the shift from syndrome to disease is it important, and does this term syndrome per se undermine the seriousness of the Sjogren's in the eyes of clinicians as well as the policymakers?
Thank you very much for inviting a patient to share their experience. We live Sjogren's. You all study Sjogren's, you all work for us, but patient experience is what really matters. And I'm really glad that you have asked me to share the patient's voice. I have lived with Sjogren's for over 2 decades, and I have talked to about and be supported more than 600 patients and families. So it is with a lot of patient experience that I come to what say what I'm saying now. Uh, the shift has happened from Sjogren's to Sjogren disease. It has taken several years for that shift to happen. A very rigorous process at the international level was followed for this change in nomenclature. And who was at the head of this change? It was patients' bodies. The Sjogren's Foundation was instrumental in suggesting this change, having listened to thousands of patients and having found that syndrome was just a collection of symptoms, and it never kind of got the respect and the dignity that the disease actually is. We heard Dr. Yaram, who very clearly explained that Sjogren's is so much more complex than just Sika. And yet, most patients find that their disease, their symptoms, their problems are often dismissed by doctors, saying that Sjogren's is just a nuisance disease. I've heard that myself several times. So the non-serious attitude towards Sjogren's is what patients have found for several years. And it is not only that, then clinically it was examined, and several doctors were part of that panel. There was a whole series of questionnaires which were sent to both clinicians and treating doctors and patients. And together, after that whole process, which started first in 1920, 2021, and which has finally been published last year, that whole process has been very rigorous. And I think very, very justifiably, the word syndrome has been dropped, and the word disease is now the terminology to be used. Uh, so that is what I would like to say. And definitely, we as patients are more hopeful that the disease will be taken more seriously, not only by the treating physicians, but also by the research and the pharmacological companies. Because in 90 years after the disease was first identified, we still do not have a single test which can identify the confirmatory disease. We do not have any single medication which definitely treats Sjogren's. We are still using medicines for lupus, medicines for rheumatoid arthritis, and we are hoping that it will show some results in Sjogren's patients. So I definitely feel it's a welcome change. Thank you.
No, great to hear that, especially from the patient herself. And it does create an impact, especially when you have under one umbrella the clinicians and the laboratorians. It does bring about the seriousness of this disease, and how this disease, the awareness on this disease has to be more, so that the healthcare industry can sort of work together and bring about a paradigm shift in not only the diagnostic aspect of the disease, but also the therapeutic aspect of the disease. So, my second question to you would be, what should be the key areas where patient advocacy groups can interact with the government and healthcare professionals to increase sensitization and awareness of this disease in India?
To my mind, the first point of attack is we need to enhance awareness. And sorry to say, awareness even among primary physicians. Most patients take from an average of 5 years to sometimes as long as 20 years to get a diagnosis. I recently heard the story of a patient who lives in Mumbai. She was 8 months pregnant with her SSA and SSB positive, and yet she had to undergo a bone marrow biopsy because the doctors did not think of sending her to a rheumatologist and sent her to a hematologist. Now, if that happens in Mumbai, can you imagine what happens to patients who are in very, very remote places, who do not have access to tertiary specialists, who do not have even MD physicians around them? So it's very, very difficult to actually uh, say that the disease is easy to diagnose. Those who have access to tertiary institutes, to good ophthalmologists, to good dentists, to good physicians, may be in a better position. But that is not the case with India. India is a very, very different and difficult country, because we have most of our population living in villages and in small places. Tertiary specialists are available only in big cities, and accessibility, affordability becomes a big issue and challenge for patients to get a diagnosis. So that if to my mind, first all these things have to be sorted. When we look at the government policies, rheumatic diseases as a whole also don't exist in their vocabulary. We tried to file we tried to find out uh, whether government departments, government hospitals had rheumatology departments. Most didn't. So rheumatology itself is not important. Sjogren's is just one of the most neglected of the rheumatological diseases. But even the other more well-known rheumatoid arthritis and other things is difficult to uh, be a part of the government system. We tried to find out if people with rheumatological diseases would get any concession in their work and all. One of our studies showed that 54% of Sjogren's patients, their careers were impacted due to the disease. Now, when you're talking about such a large percentage of people having to move out of the workspace or having to compromise on their careers because of the disease, and yet there is no recognition of this being a disability, because visibly we are not disabled. So that is a major a problem. But like I said, the entirety of rheumatological diseases are not even there on the radar. So Sjogren's finding a place is kind of many years down the line. Advocacy for these issues is not easy. We look at the budget allocations by the government for various purposes. We have a big budget allocation for non communicable diseases. But rheumatological diseases, and therefore Sjogren's also, has no place in the non-communicable diseases. So where do we exist? We always fall in the cracks. There is a move towards rare diseases. So rare diseases has managed to get a policy for its own, and rare diseases works. Non-communicable diseases like uh, blindness and other issues have got allocations of budgets. Rheumatological diseases have not got even a recognition in that list. So, at many levels, advocacy is needed. We do not get supported by insurance. So, that is another big problem for patients. When we are talking about such expensive tests and procedures, how do most patients even afford these tests? You may have probably the most wonderful tests for ANA profiling and all these tests that help us find the diagnosis. But how many people really have the affordability to access these tests? So, that there are multiple levels at which the problems have to be addressed. And to begin with, I think if we can even enhance the understanding, and we can improve the diagnosis of one of the most prevalent, yet most neglected of the rheumatological diseases, I think the patient community would be very happy to have even that step forward. So thank you.
Yeah, right. No, great, great, Miss Kirtida, and I guess you have let the pain be felt by the panelists of a pain of a patient and how everyone should collaborate together to come together and sort of do more for this particular disease, more so when it is just a small chapter in the textbooks. And while going through the the preparation of this webinar, I was pleasantly surprised to come across a book which was totally devoted to Sjogren's syndrome, and I put the excerpts of those in my presentation. So that was a pleasant surprise when you have a book titled Sjogren's syndrome. Unfortunately, not Sjogren's disease, Sjogren's syndrome. So it was a good surprise to have to read through that book, and really happy that somewhere it is now getting the place it warrants amongst the healthcare professionals. So no, wonderful. So I guess we have had a good round of discussions and we need to wrap it up. So, to conclude, I would like to put across a question, and then I would request each panelist to give their thoughts on it. And basically, the I wouldn't say a question, but a statement which I'll put forward in the context of India as a country. How can we address the multifaceted challenges of diagnosing and managing Sjogren's syndrome, particularly in rural areas, given, as Ms. Kirtida said, given the lack of specific treatment plans, changing age demographics, socio-cultural barriers, limited awareness among primary physicians, and the fact that it's not recognized under the Disability Act. Also, what role should national guidelines and inclusion in the medical curriculum play in improving early detection, quality of life, and access to care for these patients? And now I would request Dr. Swati to give her inputs on these.
Thank you, Dr. Siddharth. I think thinking about the patients, the key point which you raised is the early detection. For any disease in India, the early detection still remains an issue which we need to address. And I think being in India, and as Kirtida said, the various limitations and issues of being in a developing country, we have a very big positive side with us, that is our population size. So the number of patients that we see are not as common as seen in the West. So we have that advantage with us where we can have like registries are coming up. So now we have a Sjogren disease registry of India where multiple rheumatology centers have tied up. LVPI is also part of that, where we are collaborating the data from Indian population. Like you showed the percentage of antibody positivity, but that is typically a Western based data. We do not
Right.
know how many of Indians have those positivity, how many of different conditions can we have, and until unless we put down a literature and evidence based data showing the prevalence of the disease as well as the different signs and the spectrum of the patient that we see, then we'll be able to put forth the guidelines for the government to make, or even for the early detection of the patients, training the other people, training the primary care physicians with the ocular involvement testing and everything. So that all will follow with, you know, so mm, collaboration is definitely a key, being a multi-systemic disease. So rheumatologist, ophthalmologist, and it's a great that you have a panelist where we have the expert laboratory people who can, help us to identify and make a positivity rate of antibody testing better. So all these people, all these arms should come together to build a robust uh, system which is Indian based, to identify these patients early as well as being able to offer them the right kind of help.
No, great. And good to know registry is in the process of being set up, or rather has been set up. So I guess that's a great step forward. Yes, great. Dr. Basu, your inputs, please.
No, I think it's a very important issue, and I agree that we need to have a combination of an approach which has the combination of empathy along with clinical research, and also pharma research, all of these elements together, and at the same time remain grounded to the realities of patients with Sjogren syndrome in our country and the problems that are specific to them. Just to give you an example, in when we have patients with dry eyes, and the most common medication that we prescribe to them are lubricants, and it's even today in India it's very very difficult to find affordable preservative free lubricating eye drops. It's almost impossible to find, and it is so essential because there are so many patients who not only are suffering from the disease but are also facing problems with the preservatives that are there in the eye drops because we don't have alternatives. And it is such a third world problem, and it is we need to work together. Everybody needs to collaborate, put their heads together. And I've been lobbying with the Indian, at least ophthalmology pharma industry, to come up with these solutions, and it looks like there are some in the pipeline. But That is the extent of the problem, and it extends to all facets of the disease. So a lot needs to be done, and I think the main thing that needs to happen is that all the stakeholders need to join hands and collaborate to find those solutions.
Oh, great, great. Thank you, Dr. Basu. So I would request Dr. Yeram to share his thoughts on this.
Yeah, before answering the question, I'll just give you one case scenario. A middle-aged female comes to my OPD. She's a software engineer, and her only complaint is fatigue. So I'll ask her, "What is your complaint?" She will be telling fatigue. So what more can you add to that? She tells that I cannot sleep. So this fatigue is bothering me, and it is bothering my work life. I cannot sit on the desk. I cannot see the computer. So tell me more about your complaints. She did not tell any complaint other than fatigue. So while I was examining her, just I asked her to open the mouth, and she had multiple caries too. So she did not know that she has this oral dryness. So she was not aware of that. So the most important thing is we should go back to our park community medicine, IEC, information, education, and communication. So patient awareness is important, and more than that, the physician awareness is also more important. So they can refer to the patient to the rheumatologist and ophthalmologist. So we can screen the patients, and after screening, we can label the patient, and after that, appropriate treatment can be given. So this education, communication, and information activity, both for patients and physicians, is the most important and pivotal step. That is the need for the day, which I feel.
No, great, great. No, that was a really interesting case which you shared, and I believe dentists are also ones who need to be aware of this disorder, or rather this disease. And I guess a lot of cases go undetected, where people keep frequently going to the dentist, get their caries treated, come back with other caries without actually going to the root cause of the problem. So very well put, and thank you so much, Dr. Yeram, for that. Moving to the laboratorians, Dr. Arpita, your thoughts on this, please.
Yeah, so I will just continue on what Dr. Yemen just shared that I mean this is a disease in which a definitely requirement of a multi-speciality team coming together, working together, whether it is ophthalmologist, rheumatologist, dentist, and like we just mentioned, there are so many papers in the literature where this got diagnosed from dental caries cases coming up. And so all the healthcare professionals coming together in a comprehensive way for to ensure an accurate and early diagnosis is very important. And of course, that will come from awareness like on the patient as well as the physician side, especially in our primary suburban and rural kind of setups where the facilities and the awareness both are limited in our resources. Like Dr. Swati says, the National Registry of Jogrens is something that has come up and will possibly of big use there. Uh, there can be incentivized research grants that can be given out for the Indian population specific studies that will bring us more focus on what the antibodies are in the Indian population, which might be different from the Western population because. Like Dr. Swati just said, we in the sort of a population we have a huge set of absolute numbers of sovereigns that India would have rather than the global population. And just to share an interesting, the publication that I was reading up. Apart from this SSA and SSB and the Rho ones, there are some novel autoantibodies that are being worked up in SS, still under the research. This thing is the anti-salivary protein one, anti-parotid secretory protein. So these are other autoantibodies that is still in the research. This thing. One thing that, from the laboratory perspective, will be needed is again to how to make these tests accessible as well as affordable to our masses. That is very important. How to get down the cost, how to get a program around it, a national program, visibility to this disease All this together, working hands will what will help us give a direction in this disease.
No, great. Thank you, Dr. Arpita, for your wonderful inputs. Dr. Monica, I would love to have your thoughts on this. Dr. Monica, you are on mute. You are on mute.
Sorry. So, Dr. Siddharth, whenever I present about autoimmune disorder, I can sum up the pain Kirtida ma'am has shared in few words, that having a systemic autoimmune disease is like riding a wave of pain, emotion, and physical limitations. It drains you entirely. You are constantly being pushed to your breaking points, and it never ends. So we can easily understand what the people with autoimmune disorders are going through. So diagnosis is a key. Early diagnosis is a key. So if the patient is diagnosed on time, the proper management can be started immediately. So if there is a delay, then there is a disease progression, and later on complication may further worsen the things, and the patient ends up with all the possibility of any improvement or any quality of life they can even think about. So definitely there is a collaboration between a rheumatologist, dentist, ophthalmologist, as well as the laboratory perspective point of view. Sometimes whatever we do, we cannot communicate, never communicate to the consultant, we never discuss the findings with the clinicians. Once you discuss with that, there is the possibility we will come out with the complete clinical picture and the diagnostic sum up and final diagnosis of the patient. I just want to share one case that was not of Sjogren but was of systemic sclerosis. The patient came to the physician OPD, and she was not aware about the skin thickening for last 2 years. And when we detected the AC29 pattern in that, 27, I immediately contacted the clinician. If there is something, you have to go for the immunoplot or ELISA for SCL70. And that patient came out positive on the same day. We diagnosed a case with the systemic sclerosis. So this is the way the patient was suffering for last 2 years. So there is a very good collaboration between a laboratory person with the clinician is a must requirement, especially in the if you are diagnosing any case from a periphery. Urban, you many clinicians are available, many rheumatologists are available, ophthalmologists are available, but for the periphery, they're not even aware about what are autoimmune disorders.
Right.
So awareness is the key. We have to actually conduct these kind of webinars for the general population also, for the peripheral in their language, to increase awareness. Post covid, there are lots and lots of vasculitis cases are there. Autoimmune disorder is increasing day by day, they are increasing, when people are now little bit aware, but that much, no. We have to work very hard on that, and government should take step for increasing awareness, and as a clinicians and as a laboratory person, we also contribute into that, and research also, as what Dr. Swati has well said. Thank you so much, Dr. Swati.
No, great and very well put. I guess it's the communication barrier between the clinicians and the laboratorians in which the patient ultimately suffers, and more so in the autoimmunity disease segment. No, thank you, Dr. Monica, for those great inputs. Miss Kirtida, you have the last word now.
Thank you for giving me the last word. And I have a whole list of things that I would wish happens, but I will restrict myself to
Please
three.
go ahead. No, please go ahead.
No, I will restrict myself to three just now, which are the most important. According to all of you have said, awareness is very important, and I really feel validated for all the work that I've done for the last 18 years, because that is basically what I've been trying to do. Awareness for patients, awareness for families, awareness for the general community. And I have been working towards this. But what inspires me now is that, although late, but now a lot of other people are getting involved, and now we have this webinar today, we have another one tomorrow, where Sjogren's is taking center stage. So, after so many years, yes, we are happy to see that other people are doing awareness and public awareness programs. My submission is that we need to start that awareness even at the level of medical education.
Right.
uh, the undergraduate education also needs to have some place for autoimmune conditions and rheumatic diseases, especially when we are talking about the topic today is a key to public health. When we are talking of public health and neglecting diseases which form a large percentage of the population, because there is lack of awareness, I think we need to start there also. So that is one of my humble suggestions. There are, of course, utopian ideas that we should have a way in which telemedicine can be successfully used, so that we have probably a trained local physician at the rural level, and we probably have a specialized doctor on other people sitting on the other end and being able to guide the local person into examining the patient and trying to. We must make better use of technology in even trying to reach all these laboratory requirements to smaller places and rural areas. So that is another, but that would be under the utopian dream that I have, that we should be able to do that eventually. And with the tech advance in our country, I think we should be trying to do that. We could take examples of such very significant projects which are happening in so many other countries, even in our neighboring countries, where we have had Sehat Kahani and so many other such successful experiments where rural urban experiments have been done and it has helped the patients. So that is one more thing that I would like to say. And the last, but which I think is the most important, is somehow, somewhere, the patient experience is getting lost. Doctors work in silos, not only within their specialties, but I don't think doctors talk to patients enough at a level to consider the value of the patient experience. I think we need to have collaborative programs between what other countries called expert patients. I'm not talking about all patients, but those patients who are capable of being involved in research, who are capable of being involved in studies, who are capable of being able to share the experience of the community, not the personal experience, but I'm sharing the experience of the community. We really need to provide for opportunities for that. I at Sjogren's India I have been doing some studies at a very small micro level within our community, and I've come up with a lot of interesting observations. But is there a way where I can actually collaborate with a scientific institution or with doctors, and we could take these studies to a much uh, more significant level of understanding? Like you already mentioned, India is a different area. I mean, we cannot follow American and European guidelines and treat our patients. Our patient community is different. So, don't we need to study that patient community? So I would really like to have more opportunities where patients can get involved in real research, get involved in the science of what we need to do, and that would be a wonderful way in which we can actually bridge the gap. So
Yes.
thank you for listening to my views. Thank you so much.
No, no, great to have your views, and these are the most important views coming from
Yes.
a patient perspective. I guess these are the points which need a hard look going forward. And I must thank you for sharing these thoughts with the panelists out here. And maybe this will be something which will be propagated outside this panel window, and more will be done going forward for this particular disease. So I guess we are now out of time, and I can just say thank you to all of you for coming together on a Tuesday evening to talk about this a small chapter in the textbook, as we have all read in our medical curriculum, but now which is hopefully gaining prominence, and very soon we'll have some better diagnostics and better therapeutics for this disease. And I thank all the esteemed panelists for the wonderful insights they have shared on this disease. And thank you all for taking out your valuable time, and wish you all the very best for the evening ahead. And with that, I'll end the session. Thank you so much.
Thank you.
Thank you.
Thank you
Thank
so
Thank
you.
much. Thank you.
Thank
Bye
you.
bye.
Thank you,
Thank you.
everyone.
Have a
Bye.
great evening. Thank you.
Great. Bye bye.